Welcome back, everybody. We're going to talk here about the management and approach to the infertile couple. Now, this requires you to have a very good grasp of gynecology because there are a lot of conditions that can lead to infertility. And there are also some conditions that lead to infertility because it is in the male. So you will want to understand some of the male physiology as well. We're not going to go into these disorders so much because I do talk about them in the gynecology section. So this is really the summation of gynecology because it requires you to know so many details about gynecologic disorders and now apply it to a big problem that happens for a couple, which is infertility. Now, we're not going to go into too great of detail into all of the causes of infertility and the fine details of the workup. This is a very complex and very detailed topic. As a matter of fact, reproductive endocrinology and infertility is a subspecialty of OBGYN. And so these physicians spend an extra 3 years beyond their OBGYN residency, which itself is 4 years. And so there is lots of topics that we could talk about in infertility. I'm just going to go over the basics, things that you will want to know as a general practitioner and that you'll want to know for the exam. If you haven't already, please consider subscribing to my Patreon page at www.patreon.com/pwbmd. You can click the link below in the description of the video or on the I button on the upper right hand corner of the video. And that should link you up. If you consider chipping in $1 a month, a little bit goes a long way to help keep these videos free. If you subscribe, you'll have access to some of my premium videos in which I go over case reviews and how to form a differential diagnosis and treatment plan. And that should be very helpful for you for clinical practice and as you get ready to prepare for step 3 of the USMLE if you're not already. So we're going to do a quick overview, talk about what infertility is, what it isn't, some terminology that you'll want to have straight. We'll talk about the evaluation, namely going into the physical exam and keying in on some things that will pop up that may give you a hint as to what the cause is of the infertility. We'll talk about the general workup, keeping in mind that your evaluation is going to give you some hints, but there are some general things that we do for everybody as part of the workup. We'll talk about the treatment, and then which of course is going to vary based on the suspected cause. And then we'll recap, and then I've got some practice vignettes to try to put this into perspective here. We have some sample USMLE style questions. So infertility is defined as the inability of a couple to conceive with regular intercourse in the absence of contraception. And the time that they have to be trying to conceive is going to vary depending on the woman's age. So it's got to be 12 months or longer in women under the age of 35, but we cut it off a little bit sooner in women over 35. I'm not exactly sure why we do that, but that is part of the definition. So 12 months or longer for women under 35, 6 months in women 35 years or older. Please, please, please bear in mind, infertility is an inability to conceive. It's not recurrent pregnancy loss. Your differential is going to vary considerably if you're dealing with a couple with recurrent pregnancy loss. So you have a couple who has had 8 pregnancies and 7 of them or 8 of them have all terminated spontaneous abortion in the first trimester. It's going to be something totally different. There you're looking at possibly like a genetic issue, a balanced translocation, something like that. Those patients can conceive, but they have issues with pregnancy loss. When we're talking about infertility, these patients can't even get pregnant. They never have positive pregnancy tests. This is different than recurrent pregnancy loss. So I want to differentiate 2 things here, primary infertility and secondary infertility. So in primary infertility, the couple meets this definition where they've been trying to conceive and it's been 12 months under the age of 35, 6 months over the age of 35. But these patients have never been able to conceive. And usually we're looking here at the woman. but depending on how long this couple has been together, but they've never been able to conceive together. All right, that's primary infertility. They've never been able to conceive. The prevalence of primary infertility goes up with age. And here we're talking again about the age of the female partner. Men don't have as much a problem with that. You have a 25-year-old guy and a 70-year-old guy. Both of them can get women pregnant. With women, obviously, much different. Secondary infertility, the couple meets the definition of infertility, but they've been able to conceive before. So let's say that the couple, they're both 24 years old, conceived a baby, had a baby, now they're 28, and they're trying to have a baby again, and they've been trying for 2 years, and they're unable to conceive. That's secondary infertility. They've been able to conceive before, and now they meet the criteria for infertility. Fecundability is just a probability, and it's the probability of achieving pregnancy per cycle. So it's just a statistic. Usually it's around 20 to 25%. So in any given cycle, if a couple tries to get pregnant, they have about a 1 in 4 chance of getting pregnant if they're having intercourse during her fertile period. It is lower with increasing age of the female partner, as you can imagine. So this is fecundability. The fecundability rate goes down the longer it takes them to get pregnant. And all that is just showing you is that they're more likely to have infertility issues if it's taking them too long. The longer it takes them, they're more likely they are to have infertility issues. But the average is about 20 to 25% in the general population. This is a statistic I found of 867 women from the general population having unprotected intercourse with a male partner. Pregnancy rates were reported at 54% within 6 months, 76% within 12 months, 89% within 24 months. So note that the majority of women get pregnant within 6 months. But that rate starts to trail off the longer it goes, and that's just a reflection of this fecundability. So the longer it takes them, the less likely they are to get pregnant at all without some kind of intervention, which we're going to talk about when we get to treatment. So the rate of conception goes down the longer it takes the couple to conceive. So what do we do to evaluate these patients? Very, very important that you get a good history. And here you're going to approach this couple as a couple. So you're going to be interviewing both the female and the male. So what you first want to know is some characteristics of the infertility. First of all, have they ever conceived before? Have the two of them conceived together before? That's going to help you differentiate between primary and secondary infertility. If they've conceived before, then maybe there's something that's happened since then that's caused them to not get pregnant. And usually that's going to be in the woman, not in the man. But it really can vary. Has either member of the couple conceived before? So if he's fathered children before, it's probably not a problem with his sperm. And that's really the only thing that's going to go wrong for the male. For the woman, there's all sorts of things. It can be anatomic, it can be ovulatory. So if he's fathered children, then it's probably not him. If she's mothered children, if she's been able to conceive, but he's never fathered children, then it tells you that it may be him. So you can get some hints from that if one member of the couple has conceived but the other has not. Menstrual history and ovulation. So has she ever had a period? Primary amenorrhea, they're not going to get pregnant. Okay, you have to elucidate the cause there. Does she have regular periods? If her periods are irregular, then it's going to be very difficult to time when they should be trying to get pregnant. How long are her cycles? Does she have symptoms with her periods? If she might be bleeding, but she's not having any symptoms with her period, she should be having symptoms with her period, and that's going to be things like mid-cycle pain, a little bit of pelvic pain, Mittelschmerz, some cramping, maybe some bloating. So we want her to be having some symptoms with her periods, not to the point of pain though. If her periods are painful, that points you more towards endometriosis. So she should be having some symptoms like cramping and irritability and bloating, but she should not be having significant pain during her periods. What about intercourse and sexual history? How often are they having sex? If they're just doing it one time a month, and let's say they're doing it a week after her period, after like day 7, they're not going to get pregnant. They need to be having sex during her fertile period, and so this is why it's important to try to educate them on maybe doing a basal body temperature diary, and so when they hit that peak, then that's towards when she's going to be more fertile. So you want to know when they're having sex. If they're having sex every day, well, that's good for them. But you want to know when they're trying to conceive. Is it painful? Sometimes, if a woman, she's got pain when she's being penetrated, that can make it difficult for the man to get his penis in all the way into the vagina and ejaculate in the correct place. What is his libido? If they're not having sex very much, well, then that can be a problem. But if his libido is really low, that suggests possibly an androgen deficiency. And that can affect the sperm quality and the sperm count. So that's something that we want to know. Does he have a normal libido? Is his libido trailed off in the recent past? And then when did each start puberty? And you're going to want to do a physical exam on them, make sure that they're both Tanner stage 5. Okay, assuming that they are, you're dealing with adults here, they should be Tanner stage 5. Past medical history, weight. This is really important for her. If she's on the extreme ends of BMI, so very underweight or obese, that's going to affect her fertility. So think of fertility like an inverted U curve. You're going to have difficulty with fertility if you're very underweight or very overweight. So you want to be in the middle, ideally around 20 to 25 for a BMI. Certainly if she's very underweight, she's going to have secondary amenorrhea. You see that a lot. What about history of STDs? Very, very important, especially for her, because a history of STDs may indicate chronic pelvic inflammatory disease, which can cause adhesions and block the oviducts. Genitourinary infections, chronic illnesses, medications. Some of the medications can interfere with the hypothalamic pituitary gonadal axis, HPG axis, and the ones that come to mind for me right away is some of the antipsychotics. And we give antipsychotics now a lot of times for depression, for treatment refractory depression. And so those can interfere with the prolactin, and that can interfere with periods. And so that's something that we want to know. Past surgical history. Has she ever had any gynecologic surgery? Has she had DNCs? As we're going to see, DNCs are associated with something called Asherman syndrome, which causes adhesions in the uterus. And so that can interfere with the ability to get pregnant. If she's had an oophorectomy, typically they're okay if they're younger. They're still ovulating, but as you get older, it's going to be more difficult at an earlier age than if she has 2 ovaries. Has he had any genitourinary or inguinal surgeries, things like vasectomy? Obviously, that's going to make it more difficult to get pregnant. If he's had reverse vasectomy, that is associated with a somewhat lower rate of being able to father children than if he's never had a vasectomy. Orchidectomy, obviously, if he's had 1 testicle removed, that can cause problems. And herniorrhaphy. Social history, alcohol abuse is associated with lower fertility rates. Drug use, including anabolic steroids, and that's because you can, if you've been using anabolic steroids and you stop, you can suppress the androgens. And then stress. Stress has actually been associated with lower levels of fertility too, but I don't think it's going to be that much. Physical examination for the female. So first you want to look at her general appearance. Is there an abnormal body habitus? So one of the things that you might look out for, and this may come up on a test question, I can't imagine it coming up in real life because usually it gets diagnosed earlier, but look for... Look at her habitus. So is she obese? Well, certainly PCOS. But the one that I want to draw your attention to, because it could come up in a test question, is does she have things like a webbed neck, a short stocky habitus, the square-shaped shield chest, widely spaced nipples? What is that? That's Turner syndrome. And you would expect that to be accompanied with primary amenorrhea, or at least delayed menses. So that's something that may come up on the test. Is there a lack of secondary sex characteristics? Again, coinciding with Turner syndrome. What about the skin? Hirsutism and acne. That suggests increased androgens. That's associated with PCOS. Head, eyes, ears, nose, throat. Is there abnormalities of the thyroid gland? May suggest, if you have a goiter, may suggest hyper or hypothyroidism. If there's nodules, that may be causing a increase in thyroid hormone. That can interfere with menstrual cycles and ovulation. Is there male pattern balding? Again, androgens, that's going to be associated with PCOS. PCOS, very common cause of infertility. Breasts, are they underdeveloped? Is there expressible milk from the nipple? So underdeveloped is going to be delayed immature secondary sex characteristics. Expressible milk from nipples, what would that be? That would be hyperprolactinemia. And that's obviously going to interfere with fertility. Abdomen, is there abdominal striae, truncal obesity? This suggests Cushing's syndrome, and Cushing's syndrome is associated with lower fertility rates. And then a pelvic exam. External, is there a lack of pubic hair? That suggests delayed secondary sex characteristics. Vaginal and cervical. Here we're looking for a patent cervix. If her cervix is closed off, you're going to run into problems. Again, usually you pick this up earlier on before she tries to get pregnant, but certainly the sperm aren't going to be able to get up into the oviducts if the cervix is not patent. Uterine adnexal, you're looking for structural abnormalities, fibroids, retroversion of the uterus, tender nodules. These last two things are associated with endometriosis. If there's pain, adnexal tenderness, that may suggest endometriosis as well. Endometriosis definitely reduces fertility. Hey, what about him? General appearance. Eunuchoidal habitus. You could easily get this on the test. What's a eunuchoidal habitus? It would be things like long arms and legs and an upper-lower body ratio of less than 1, meaning just really long legs. And what is that? You got a guy coming in, real long legs, kind of hourglass appearance, kind of more feminine appearance, and long arms, taller. What is that? That's Klinefelter syndrome, and they're going to have fertility issues. Sometimes that doesn't get diagnosed until this point. Obesity and decreased muscle mass, that suggests androgen deficiency. How about the skin? Absence or loss of axillary and facial hair, androgen deficiency. So a good thing to ask the man, if he doesn't have a whole lot of facial hair or axillary hair, is this a recent thing? Have you noticed that you go longer without shaving? I can tell you this, the older I've gotten, I'm in my late 20s, the older I've gotten, the more I have to shave. I used to only have to shave every 3 or 4 days. Now it's like every 2 days. So it's getting really bad. But it certainly shouldn't be getting longer. The periods where you're having to shave shouldn't be getting longer. Of course, if he grows his beard out, then that might not work as a question. But if he's shaving, his facial hair should be growing faster. Definitely never slower. Breasts, gynecomastia, that suggests issues with elevated estrogen. That could be from liver issues. Lots of things can cause gynecomastia. You want to look for that. It could be hyperprolactinemia. And then pelvic, look for things like inguinal hernias. You want to look at his penis. If there's absence or loss of pubic hair, that suggests androgen deficiency. That's going to affect the sperm. Abnormally small phallus, that is going to be seen in Klinefelters. Scrotal and testicular, if there's undescended or absent testicle, if he's only got one testicle, that can cause a problem and may reduce the sperm count. Absence of vas deferens, this is not something that's really easy for a general practitioner to be able to evaluate. So sometimes it may be useful to send these men out to a urologist who's got special experience in dealing with this. Epididymal thickening or cysts, you might use an ultrasound to look for that. Varicocele, indirect inguinal hernia. Those are relatively easy to pick up on physical exam. So what do we do for workup? This is important here. So you want to write these things down. These ones that are starred, this is the fundamentals of the infertility workup. Semen analysis. Always, 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 you're going to get a semen analysis. So you're working up both the man and the woman concurrently, simultaneously. So you get a semen analysis. You're looking for the quality of the semen count, the morphology, the motility. You're going to then also assess the ovulatory function. So here we're looking for, is she or is she not ovulating? And what you can, the easiest way to find out is by getting a mid-luteal progesterone level. So if she has 28-day periods, 28-day cycles, what day are we going to get? What day is it going to be mid-luteal? So the luteal phase begins at what day? At the LH surge at 14 days, and it ends at 28 days. So you want to get at day 21, you'll want to get a progesterone level. And so the level, you can look it up if you want, but I believe it's 3 nanograms per milliliter would be normal. Anything less than that is suggestive of inadequate ovulation. So an abnormal mid-luteal progesterone level suggests amenorrhea. And at that point, then you'll want to get a serum prolactin, FSH, and TSH. And then you'll also want to assess for PCOS if there's other signs, if she's overweight, if she's got facial hair, if there's any kind of virilization, acne, signs of PCOS, you want to get an ultrasound and look at her ovaries. And then an assessment of ovarian reserve. So here we're looking at FSH and estradiol levels. You'll get that on day 3. If that's abnormal, then that typically will suggest either menopause, which we would consider if she's older, late 40s, or premature ovarian failure, which certainly can happen in younger women. And that's really unfortunate. And so the way we're going to get around that is by giving her medications to try to stimulate her ovaries. So remember that FSH, what do we expect that to do? When you hit menopause, does FSH go up or down? If you stop ovulating, you hit menopause or premature ovarian failure, is FSH going to go up or down? So FSH is going to go up. FSH goes up when you hit menopause. And the reason is because that follicle makes estrogen. And so if the follicle is not making estrogen, then it reduces the negative feedback on the pituitary and hypothalamus. And so that's going to increase the amount of gonadotropin-releasing hormone, which comes down from the hypothalamus, goes to the pituitary, and stimulates FSH and LH. So you release that negative feedback, you have more GnRH, and you have more FSH. So we want the FSH levels to be lower. Adequate ovarian reserve, you should have 10 milli international units per milliliter or less. Okay, so a high FSH suggests inadequate ovarian reserve, suggesting menopause or premature ovarian failure. You can also get estradiol levels. I'm not sure what the levels are for that. You could get just the FSH, or you get FSH and estradiol levels. So these 3 things you always, always, always get. Now, hysterosalpingogram, you may include that as part of your initial workup, or you may wait. So if you come back with an abnormal semen analysis, and her ovulatory function, her ovarian reserve are normal, then it's probably a problem with him. And so you can try doing the treatments for the semen issues, which we're going to talk about in a little bit, assisted reproductive technology, and see if that works before you do a hysterosalpingogram. Hysterosalpingogram is a slightly invasive test, so we want to avoid that if we can. However, you may include that as part of your initial workup. It's really just a clinical judgment call. So a hysterosalpingogram is an imaging test. You use a dye, and then you image, and you're looking at the anatomy of the uterus and fallopian tubes. And particularly here, we're looking for issues with maybe adhesions or blocked tubes. And this can be, as I said, performed as part of the initial workup, or it can be postponed until you get normal semen analysis, ovulatory function, ovarian reserve, and you're looking into greater detail here. If this is abnormal, typically it's going to be reflective of tubal damage. At this point, you can do a laparoscopy. Laparoscopy is done to further visualize the abnormalities, and at that point you can try to do a tuboplasty to open the tubes up, and in many cases that can help. So the goal of treatment is to counteract or correct the underlying cause of any factors that may be contributing to infertility. So let's say everything came back normal except for his semen. In this case, we do assisted reproductive technology. So what's the most common issue with the semen? It's going to be a slightly reduced sperm count. And so if the sperm count is slightly reduced, and you can look up the normal numbers, but I didn't include that in here because I don't want to bog you down in details. But if you have a slightly reduced sperm count, what you can do is you can concentrate that ejaculate and wash it, and then what you then do is you inject it directly into the uterus. And so that helps more sperm get to the egg. So it's just like artificial insemination, but you do some extra things to the semen, and then you inject it directly into her uterus. And you want to do this, of course, when she's ovulating. Severe abnormalities, this is going to warrant in vitro fertilization. So what you do is you retrieve one of his sperm, you place it into an egg, and then you transfer that egg to her uterus. So you have to retrieve eggs, put the sperm in the egg, and then put that up into her uterus. This is expensive. Okay, this is if there's severe abnormalities, so issues with the motility of the sperm, issues with morphology, things like that, not just a decreased density. Certainly, though, very severely decreased density, you may need to go this way too. So real severe abnormalities, you're going to do in vitro. If there's an absence of viable sperm, then there's no way he can father children. And so in this case, for them to get pregnant, for her to get pregnant, you'll need to use a donor sperm, artificial insemination with donor sperm. Well, what about for her? If she's not ovulating, then there's a number of causes. First, we want to look to see if there's an underlying cause. And this is why, if she's not ovulating, we got to get those tests, the thyroid stimulating hormone, the prolactin levels. You want to get those because it may point you towards an endocrine issue, or it may be PCOS. PCOS has some really good clinical symptoms that are easy to pick out, and you can confirm this certainly on sonogram. So these three things, you can treat the underlying cause, and that itself may allow them to get pregnant once it's treated. If it's idiopathic or if it's due to menopause or ovarian dysfunction, then in this case we want to stimulate the ovaries to release an egg. And so we do that by giving clomiphene citrate, and this stimulates the ovaries to release an egg. Clomiphene is a non-steroidal SERM, selective estrogen receptor modulator. What it does is it blocks the estrogen receptors in the hypothalamus, which inhibits that negative feedback of estrogen on the hypothalamic pituitary gonadal axis. Basically, you can think of it as an anti-birth control. It does the exact opposite as the oral contraceptives, and it triggers the GnRH to become more pulsatile, and that eventually is going to cause the ovaries to release an egg. Now, the problem with this is that it can cause hyperstimulation of the ovary, so you may get more than one dominant follicle and multiple eggs are released, and that's why we see a higher twinning rate with clomiphene. You're more likely to have multiple gestation. The second, there's also a second-line agent that can be used. That's human menopausal gonadotropin, so you can use that if clomiphene fails. And there's other drugs aside from clomiphene, but this is the sort of the cornerstone medication. This will be the one that comes up on the test. Letrozole is, I think, another one that you see. If there's tubal damage, as already mentioned, you can do tuboplasty, or you can do in vitro fertilization. It's going to be hard to get pregnant the natural way if you have tubal damage that can't be that can't be reversed. So in vitro fertilization, and if it's just tubal damage, her uterus should be normal, so you can do in vitro fertilization that way. So just to recap, infertility is defined as the inability to achieve conception after 12 months of regular unprotected intercourse if she's under 35, or after six months if she's over 35. Remember, primary infertility is infertile and never conceived. Secondary infertility is infertile now, but they've conceived before. Assessment includes a detailed history and focused physical examination. You want to get a good idea of the woman's ovulatory status, if she's got irregular or absent cycles, and an STD history, which suggests possibly that there may be chronic pelvic inflammatory disease, which can lead to tubal damage and adhesions. You also want to know if she's had abortions. DNCs can cause something called Asherman syndrome, which I already mentioned, and that can cause damage to the reproductive tract as well. Initial workup should include a semen analysis, assessment of ovulatory function, which is a mid-luteal progesterone level, assessment of ovarian reserve, which you get a day 3 FSH level, and a hysterosalpingogram. And you may do that after you do these first 3 and then wait to do the hysterosalpingogram, or you might just go straight into it. I would say just base it on your suspicion. If you suspect, if she's got a history of multiple DNCs or STDs, pelvic pain, you might just go straight in and do the hysterosalpingogram right away because your index of suspicion of there being anatomic issues like adhesions and inflammation is much higher. So just use clinical judgment. Further workup may be undertaken, things like getting TSH and prolactin, depending on clinical suspicion or the results of initial workup. Certainly, if she's got PCOS signs, you want to do a sonogram of her ovaries. Bear in mind that 30% of infertile couples, you won't be able to find a cause. And in that case, if they're idiopathic, you'll want to try, the best way to go about that is to try ovarian stimulation with clomiphene. Treatment depends on suspected cause. Assisted reproductive technology and clomiphene are very commonly used. So let's try a practice vignette. This isn't really a vignette, this is just a question. Which of the following is never part of the initial workup for a couple with infertility? A, hysterosalpingogram, B, laparoscopy, C, day 3 FSH level, D, sperm analysis, or E, mid-luteal progesterone level. I'll give you a chance to pause it here and look this over. And the answer is B, laparoscopy. You don't do that. You wait. Okay, if there's a hysterosalpingogram which shows tubal damage, then you can do a laparoscopy to try to correct the tubal damage, but you would never want to do a laparoscopy right away as part of an initial workup because that is expensive and it's invasive. So day 3 FSH level, sperm analysis, mid-luteal progesterone level, those are all good things to get right away. Hysterosalpingogram, you may or may not wait, but you could consider that part of your initial workup, just kind of a secondary part of the initial workup, depending on your clinical suspicion, but laparoscopy would never be part of your initial workup. Okay, we have a 28-year-old G3P1021 presenting with her husband, reporting 16 months of infertility. She's been pregnant 3 times before, once at 17 and once at 18, both of which were electively terminated via DNC. And then at 21, she had a pregnancy which resulted in a term spontaneous vaginal delivery but required a DNC for retained placenta. Her husband has never fathered a child. His semen analysis, though, is normal. Her cycles are regular, 28 days with moderate flow and accompanied with mid-cycle pain and cramping prior to menses. Which of the following tests is most likely to reveal the cause of this couple's infertility? A, ovarian sonography, B, repeat semen analysis, C, transvaginal sonography, D, hysterosalpingogram, or E, laparoscopy. All right, the answer to this one is hysterosalpingogram. So when we look at this patient, what do we see in her history? She's had multiple DNCs. That's concerning. That can cause damage to her reproductive tract. But we look at him, he's never fathered a child. Well, that's common for a, I don't know how old he is, but, for a younger guy, that's pretty common. Never fathered a child, never tried. But his semen analysis is normal, so we know it's not male factor. Her cycles are regular. That's good. She's got symptoms with her periods. That's really good. That shows she's probably ovulating. We might not even need to get tests. We do, but that's a real good sign that shows that she's ovulating. The fact that she's had all these DNCs and the fact that she's gotten pregnant before and now she's not, what do we call that? Secondary infertility. And so it's probably something that's happened. So it's probably those DNCs. And so the way that you're going to be able to tell is a hysterosalpingogram. You're probably not going to see anything on sonogram. This is likely Asherman syndrome, adhesions, and or fibroids of the endometrium, which is especially associated with DNC. And the way to manage this is hysteroscopy and adhesiolysis. As far as repeat semen analysis, when do you want to do a repeat semen analysis? If his semen analysis comes back abnormal, Sometimes the semen quality can vary with time. So if his semen analysis the first time comes back abnormal, you want to repeat that in 4 to 6 weeks because the quality of the semen can change with time. All right, so this is a hysterosalpingogram. A 32-year-old nulla gravida presents with her husband complaining of 3 years of infertility. Her husband has never fathered a child. Neither have a history of STDs. Her cycles are regular, 26 to 28 days, with moderate flow and some breast tenderness and cramping. Semen analysis reveals a moderately low sperm count, but normal motility and morphology. Her workup is entirely normal. Which of the following is the most appropriate plan to manage this couple's infertility? A. Ovarian hyperstimulation to increase odds of conception. B. Clomiphene citrate. C. Intracytoplasmic sperm injection and in vitro fertilization. D. Donor sperm. Or E. Intrauterine insemination. All right, the answer to this one is E. Intrauterine insemination. So where's the problem? Obviously, it's with the sperm. And is the sperm, how abnormal is it? So basically here you're dealing with minimally to moderate abnormal sperm. It's just a low sperm count. So what we can do is we can concentrate and wash the sperm, so that will increase the sperm count. So you might have him like ejaculate 2 or 3 times and then concentrate that sperm down, wash it, and then inject it into the uterus. That will help these patients. If there were issues with morphology and motility, then it's going to be difficult to, if you're just injecting the sperm into her uterus, it's going to be difficult for abnormal sperm to actually even make it up to the egg. So if you have issues with motility and morphology, or you have a really, really low semen count, talking more like 5 million per mil, then you'll want to do intracytoplasmic sperm injection and IVF, because you'll need to directly fertilize that egg and then put it into her. But for just moderately low sperm counts, you can concentrate and wash the sperm, put it right up into the uterus, and this is intrauterine insemination. Donor sperm is not necessary. That's only if you have vasospermia. Clomiphene citrate, that's if she's not ovulating. Ovarian hyperstimulation to increase odds of conception. This is the same thing as clomiphene citrate. If you have any questions, please write me a note below. Otherwise, I will see you next time.